All right, good afternoon, everyone. Welcome to session 6, AI or Artificial Intelligence in Disability Healthcare. I'm Jennifer Fung, she, her pronouns, a current PA student at the Stanford University School of Medicine who identifies as having a disability and chronic illness. I'll be introducing our panelists as well as moderating the Slido for the Q&A portion of the second half of this session. So please feel free to drop your questions in there throughout this wonderful session. So my visual description is that I am a mid-20s Chinese Vietnamese American woman with long brown hair and a beige blouse with purple flowers and a blurred background. This is the AI and Disability Healthcare session, which aims to explore ethical considerations and JEDI, or Justice, Equity, Diversity, and Inclusion prioritization with relevant frameworks to catalyze advancements at the intersections of AI, disability, and healthcare for a more inclusive and equitable future. It is my honor and privilege to introduce our esteemed panelists, Sonu Thathani, Israni, and Dr. Ranek Trivedi, who are overflowing with expertise in this area. Sonu Thathani Israni serves as an executive director of Presence, which is a center at Stanford Medicine focusing on ensuring that we prioritize the humans in healthcare, the ones being served and the ones serving. She spent nearly 25 years working in Silicon Valley before coming to Stanford 15 years ago. Sonu is a thought leader in artificial intelligence in healthcare and co-leads the National Academy of Medicine's Working Group on Artificial Intelligence, publishing the 2019 AI in Healthcare, The Hope, the Hype, the Promise, the Peril, in which justice, equity, diversity, and inclusion are at the core of all her work. Today, she'll share her work on AI in healthcare, which began with the National Academy of Medicine's Working Group on the subject in 2018, and she was the co-leader of this group. We also have Dr. Ranek Trivedi, who is a clinical health psychologist, having earned her PhD at Duke University and been elected Fellow of the Society of Behavioral Medicine. She also serves as a health services researcher and associate professor in the Department of Psychiatry and Behavioral Sciences at Stanford, core investigator at the Center for Innovation to Implementation, Veterans Affairs, Palo Alto Healthcare System, and Director of Caregiving and Family Systems with the Stanford Center for Asian Health Research and Education. Dr. Trivedi has been featured in New York Times, Washington Post, U.S. News and World Report, Huffington Post, local television news outlets, and healthcare podcasts. For over 15 years, Dr. Trivedi has been committed to improving the outcomes of vulnerable populations, including military veterans, family caregivers, and South Asians managing breast cancer. Now, without further ado, here's Sonu.
Thank you, Jennifer. My name is Sonu Thathani Israni, and as you heard Jennifer say, I will be one of the speakers today and take your questions. I am an ally to everybody who has otherwise been paid the price of a healthcare system that prioritizes privilege. My physical description is that I'm a South Asian woman on the right side of 60, which is my side of 60. I have mostly salt hair with a little bit of pepper. I'm going to share my slides and walk you through a short talk and then turn it over to my colleague and friend, Ranak, to present her work before we take your questions. I'm hoping you can see the slides here. First, some background. What you heard about me in my professional world is relevant. What's more relevant are the women on the screen that inspire and focus my work. All the women in black and white photographs on the screen over here are my mother, my two grandmothers, and the grandmother of my husband. The 2024 versions of these women who do not lack privilege of any kind will not be able to navigate America's healthcare system. What's worse is the women in color over there are my two daughters who have a ton of privilege. They were born at Stanford Hospital. They work in Washington, D.C., one as a civil rights lawyer and the other one in the White House. They both have amazing educations. And if their healthcare is vanilla, they can handle it. The minute their healthcare is not vanilla, they need a quarterback MD. That is unacceptable. And that is why I prioritize justice, equity, diversity, inclusion in the work I do. These are my conflicts and disclosures. The most relevant one over here is the phrase in the Devanagari script at the bottom that reads, Bhool Chuk Maaf Karna, which means, forgive me my errors and omissions. I am human. I will make mistakes. I'm not going to take the time and effort to go through a land acknowledgement, I assume and hope that happened earlier in the day, but I do want to re-acknowledge that Stanford sits on the ancestral land of the Mwekma Ohlone people, and they are a thriving community in the Bay Area today. I'm also going to add a labor acknowledgement, and the photograph that you'll see on the screen is of the railroad laborers from the Stanford archives. And these were the laborers on whose backs the Stanford family built their wealth. This screen says thank you, not because this is the end of the presentation, but because I want to take a moment to thank each and every one of you, because you are at the front line, delivering the care that matters and building the change we all believe in. Thank you. As you heard earlier, at Stanford, I am the executive director of a center called Presence. My colleague and friend Abraham Verghese is the faculty director. And we focus on championing for the human experience in medicine. And we believe being present is essential to the well-being of both patients and caregivers, and is fundamental in establishing trust for all human interactions. Being present is integral to the art and science of medicine and definitely predicates the quality of medical care. The snapshot of my work that I'm going to share today is based on a book that was published by the National Academy of Medicine, where my colleague Mike Matheny and I co-led the working group for AI in healthcare and published this book in 2019 called AI in Healthcare, The Hope, the Hype, the Promise, the Peril. If there is only one thing you take away from this talk and from the work I do, is the fact that back in 2019, we proposed that the healthcare system needs to advance to the quintuple aim. We're aware of the triple aim that focused on population health, reducing cost, and patient experience. After a long period of watching burnout, we added care team well-being as the quadruple aim. And back in 2019, we argued that we need to advance to the fifth aim, equity and inclusion, which I now call JEDI, Justice, Equity, Diversity, and Inclusion. What is JEDI? I'm going to read a few phrases here and there to help you make sure that you and I are on the same page when I use that term. Diversity for a long time has asked who is in the room, and equity asks who's trying to get in the room but can't, whose presence in the room is under constant threat of erasure. Inclusion asks, have everyone's ideas been heard? And justice responds, whose ideas will not be taken seriously because they're not in the majority. I'm going to go to the last quote on the screen and read the fact that justice challenges whose safety is being sacrificed and minimized to allow others to be comfortable maintaining dehumanizing views. So what are the considerations of JEDI when it comes to our US healthcare system? Whether it's innovation through AI or anything else, delivery and practice. Why is this prioritization of JEDI crucial? This particular slide extracts some information from a viewpoint written by Don Berwick in JAMA early last year, February of last year. And he argues that healthcare professionals in all disciplines need to become noisier about the conflict between unchecked greed and the duty to heal. He also argued that healthcare leaders and professionals should lobby Congress to pass legislation to rein in greed, and that we should insist our organizations invest actively in improving the true social influences of health. Our hospitals should bring fair share of their resources to mitigating the causes of illness, injury, and disability, and that the glorification of profit is harming both care and health. Healthcare should not be an engine for excessive private gain. The other book I'm going to refer to was written by Kate Crawford, and it's titled The Atlas of AI: What are the Power, Politics, and Planetary Costs of Artificial Intelligence? In this excellent book, she argues who has the power, what are their priorities, who benefits the most, and who pays the highest price. Going on to summarize that AI is neither artificial nor intelligent. It requires vast amounts of natural resources, energy, and human labor, a giant infrastructure project with logistical demands that span the planet. In fact, AI as we know it depends entirely on a much wider set of political and social structures. And due to the capital required to build AI at scale, and this, by the way, this book came out before the current large language models that we all read about, that it prioritizes and optimizes and is commonly designed to serve the existing dominant interests. The examples she uses are military policing and the wealthiest companies in this planet, and ends by saying that artificial intelligence is a registry of power. This slide over here shows you, on one side, a very wealthy community where each level of a multi-story building has its own swimming pool and very swanky tennis courts. And on the other side shows people living in huddled masses in what would not be called homes, given any human rights lens. This is not a photoshopped picture. This is a true picture, not in our country, but it could well be. In the year of 2020, for instance, the city and county of San Francisco minted more millionaires in 1 year than it ever had in its history. It's also the year where our unhoused population went through the roof. Because healthcare needs population representative power, data, diversity, and inclusivity, especially the assumptions that are used for designing solutions, we must first rebalance power to address health inequities. Otherwise, we will end up with what is the computer science world calls GIGO, garbage in, garbage out. I'm now going to turn it over to my friend and colleague Rana Trivedi, who is a national leader in her field, to talk about the unique and crucial needs of people with disabilities and their caregivers, specifically focusing on families and paid caregiving. I'm going to turn it over to you, Ranak, and stop sharing my screen.
Thank you so much, Sonu. I will share my screen, and then if you can confirm the slides are being shared. Can people see the slides? Can somebody give me a thumbs up? Okay, great. Thank you. Thank you, Sonu. My name is Ranak Trivedi. As has been said, my visual description is I also am a South Asian woman. I have shoulder length dark hair. I'm wearing glasses, and I'm wearing a red shirt with some jewelry, and my background is Stanford Medicine's background. It is such a great honor and privilege to be representing this area of research to all of you and in this conference. Oops, let me see. So similar to what Sonu has said, I too am motivated by my personal story. These are my parents from some years ago, and my father has had chronic heart disease for quite a long time. And about 20 years ago, my mother was also diagnosed with 22 years ago, breast cancer, which has then become metastatic over the last several years. And over the years, I've seen how they've taken care of each other as they've navigated their various health conditions and just life, certainly with the help of my brother and I. But it has inspired the research I do in focusing how we in the healthcare system usually focus on the patients while ignoring the family and the caregivers who are very much form the scaffolding of the healthcare system. Sono mentioned this term family. It's a term I've used. It's a term in the Urban Dictionary. If you look it up, it will be described as friends who are like family. And it's a term often used by people such as myself, whose families of origin are often thousands of miles away. I and our work have co-opted this term to actually refer to friends or family members in the network of individuals who have medical or mental health conditions. Because people who, if you've been sick before, or as you see your own lives, you've seen how people come together to do everything from running errands to bringing medicine to doing everything, all the way to taking care of bathing, toileting, and other activities of daily living. Caregivers, the way we've talked about that are, the way I'm thinking about them or how we define it is those people, family who provide direct support to those who have medical or mental health conditions or disabilities. And caregiving is something that's a very common phenomena in the world and in the United States. Every 5 years, the National Alliance of Caregiving and AARP do this survey called Caregiving in the US. And as of most recent data, which was 2020, more than 1 in 5 Americans care for a person with a disability or an illness. And this is typically given by family members or friends, and it's often unpaid care. There have been some growing movement to provide some stipends, but it is not considered truly paid care. So when we talk about this type of caregiving, we're not talking of nurses or nurse aides or home health care, or people who might be receiving care in specialized facilities like skilled nursing facilities. Increasingly, more and more people are caring for more than one person. So as of 2020, about 1 in 4 adults who provide care are providing care to more than one person. And what is not surprising, perhaps, is that 1 in 5 caregivers also have a disability. So it really, truly kind of brings forth this idea that we have a lot of caregiver dyads in the country and in the world, people who are taking care of each other. And a lot of the, and it's important to recognize that there's a tremendous social benefit, societal benefit, and healthcare benefit that occurs because of the unpaid care. As of the last estimate, unpaid care was estimated to be $600 billion in the United States. This is a huge amount that the society is benefiting, as well as the healthcare is benefiting, because healthcare often gets reimbursed for a lot of the activities, and the more and more care is getting pushed out to families and homes to do this at home so that caregivers or for healthcare benefits. And this care is provided by 53 million caregivers in the United States. That's a lot of zeros. And if you think about it, this is the market cap as of a few days ago when I was making these slides or finalizing the slides of companies that we know really well, Visa and Tesla. So it's one way to think about it is if caregiving was an industry, it'd be in the Fortune 10. So Sonu has already made the point that the healthcare system, the way we've set it up, is become for profit in a way that it's growing on the backs of many people, including, in this case, family caregivers. Now, there's a lot of tools that are being developed to provide care or to assist with care. And I just wanted to note that a lot of the tools that are out there are also can benefit and are being used or can be used by people who have disabilities, as well as our caregivers. I am going to sort of focus on the tools and the ways that caregivers will engage with it, but that certainly can be flipped because people with disabilities could be using these as well. as more and more tools come up with emerging AI as well as other tools, we can think of them as two buckets of care. One is those tools that reduce caregiver involvement. So you can think of things like surveillance tools or tools or robots that can help to do transfers. That means that the caregivers can then stop doing those activities, or at least reduce the time needed for that. The other is to improve ability to carry out caregiving tasks, and that falls in and sometimes there's an overlap between the two. One thing I just want to note is a lot of these tools, in fact, all of these tools really focus predominantly on the practical tasks of caregiving, caring for people who might have a disability as well as people who have a health condition. There is very little focus, if any, on the emotional needs that you would imagine comes up for both the peoples with disabilities and illness, as well as those who are caring for them. I just have this table in which I am describing some categories of the goals of caregiving and some available tools. And certainly these are not endorsements of these particular technologies, but just something to be familiar with. Tools to coordinate care are things like conversational AI or robotics. So examples are voice activated digital assistants. And there's this platform called LEQ. There are robotics to assist with activities of daily living. And an example of that is Robert. There's a sort of growing recognition of the companionship needs. And so there's been conversational AI as well as social assistive robotics that have been developed. A well-known example for a robotic is Paro, which is a harp seal. If some of you may have already seen this, have been familiar with this, and it's a harp seal that kind of is soft and it's small, and they've done some studies in nursing homes and to see if having Paro as a pet can help mitigate the isolation and loneliness that people, especially those with dementia, are experiencing in nursing facilities. And finally, there's a surveillance-based AI that can help with monitoring falls and biometric, such as like through biometric remote monitoring. An example of that is biotricity, and I think this is a very rapidly growing space, and I know there's been many examples more recent than biotricity now. So this is all great, right? We have these great tools, we have robotics, we have software. Well, not necessarily. A technology of any kind is a tool, and any tool has the potential of abuse as well as use, as well as it might open up new ways and complications that can influence what we're trying to do, improve and change the pathways of how we're providing care in this case. There's this book called Robots Won't Save Japan, written by James Wright, and it's actually his dissertation. And the way this project was started is many of you may know that Japan has been facing a caregiver crisis for a while now. There's a lot of there's a fewer and fewer people willing to provide intergenerational care. There is a strong gender expectation that women will provide care and will leave the workforce to do so. And so the Prime Minister of Japan created this massive investments in robotics. And it was released along with a report that said robots will save Japan. So the title of this book / dissertation is flipping it on its head, because what James Wright is arguing is that it is not as simple as just telling somebody to giving the care away to a hardware or a software. It actually has the potential of harm as well as just complicating the caregiving. So this is Sonu and I's friend and colleague, Dr. Andy Elder's care triangle that he talks about. And the idea behind the care triangle is a lot of times we've always thought of care, somebody caring in this, he uses the example of older person, but certainly person with disability would also fit in that, is somebody who needs the care here and the person who is providing the care. And then when we introduce care technology, whether it's AI, whether it's robots, whatever it might be, we're actually creating another vertex to this and making it into a triangle. So the things that we start thinking about is, what aspects of care can a machine even provide? How is this relationship affected by human carers or caregivers? What aspects of care can a human caregiver provide? And how is this affected by technology? And then in what way does the presence of any care technology influence the work of the human carer, the caregiver? And I think this is really important to realize, because what this basically says is that it is not just simply replacing the green box over here. We're actually introducing a different variable entirely. And there's a strong potential for harm. There's an article that just came out that Sono alerted me to, in which these algorithms that are being created to predict addiction risk of opioid prescribing are actually causing harm. So in this algorithm, it just came out in New York Times earlier this week. And increasingly, providers, clinicians are using these algorithms that can predict whether somebody is at high risk of opioid addiction. And we know that opioid addiction has become a national epidemic, and there's a lot of attention that is coming to how do we mitigate the opioid addiction in our country, and that is an absolutely worthy cause. However, in this article, they talk about how these algorithms, the way they've been built, are actually marginalizing minoritized groups such as race and ethnic minorities, especially, as well as women. So women who are having painful endometriosis are not receiving opioids that could really help mitigate their pain, and their pain is increasing, and their suffering is not getting mitigated, even if where the tools are at hand. Same things with racial and ethnic minorities, where cancer-related pain is something that is considered an indication for opioid prescriptions, and people are being denied these medications because their algorithms are predicting them as high risk for opioid addictions. And that's not the only harm that can be caused. That's just an illustration of the type of harm that can be caused. We have been working on recently with Margaret Levy and Elizabeth Foster, Andy Elder, and I have been working on a manuscript in which we are talking about how AI can be harmful. And some of the ways in which AI can be harmful is family caregivers have to learn how to manage a new system, which is a part of that triangle I just showed you. They have to learn new technology at a time when caregivers themselves may be feeling a lot of pressure to just carry out their roles. And in this particular instance, it's not just family caregivers. It could be paid caregivers that might be a home health aide or nurse aides who might be coming home to help out. They would then have to learn how to manage this new technology, interact with the new technology to make sure that it's working well. That also means that the risk for errors increase as people have to learn something that they're not familiar with. Technology can always fail, which can lead to dire consequences as well as poor health consequences. Surveillance tools can sound really good because we can make sure people have not fallen and can intervene immediately, but it then comes with loss of privacy and dignity that is fundamental human rights. And these are not a substitute for the human companionship that is so built can be so built into both paid and unpaid caregiving roles. And as illustrated by the article I just showed you from New York Times, the biases that are already existing in society are getting encoded in our AI tools so that things like the cultural context of care or aging or disability are not receiving attention. So it's perhaps not surprising that if you look at the most recent Pew data that I could find, there's a growing concern of AI tools among US adults. So if you can see in 2021, I'm showing a graph that has a bar graph, which has, it's a stacked bar graph, and it's showing across 3 years, 2021, 2022, and 2023, how much excitement people are feeling, from more excited than concerned, equally excited and concerned, and more concerned than excited. And what we're finding is that in 2021, the proportion of people who were more concerned than excited was 37%. And that number increased to 38% in 2022. And as in 2023, which is just last year, that has gone up to 52%, meaning 52% of adults surveyed are now more concerned than excited about the use of artificial intelligence in daily life. And none of this kind of factors in what we already know to be a challenge, not only of AI, but healthcare as we know it. Sonu alluded to this. Our world and our communities are very diverse. And yet the care is designed to help people who have enjoyed privilege historically. So how are we taking care of our families and of our patients and people in the community who may not just be a single just 4 people family, people who may identify as LGBTQ+, people who may be living in multi-generational families, people who may be living alone. We are not designed in the healthcare system to address the needs of all kinds of diverse groups of people. And that's something we absolutely need to work on changing. And something that should be cautionary for us as we see this world evolve. So we need to be thinking about what are the possibilities for paths forward. I spent some time describing the problems, but we need to craft a future where these problems are addressed and mitigated. The opportunities are to embed principles of equity, diversity, and inclusivity within all types of tool building. Sonu beautifully described the JEDI framework, which means that we need to build programs that engage diverse teams and shareholders at all stages of development, engage people from different cultural backgrounds, and address the biases that are inherent in our society and healthcare system around ageism and ableism. We need to think of the ethics of the tools we're building as not just HIPAA, but also the ethics of surveillance. And one of the challenges of the tools that are being built right now are they don't really fully harness the power of behavior and social theory. There's a lot of excitement to build tools that are addressing gaps that are being observed, but the solutions are often face valid and therefore they're not sustainable. There's a lot of focus on extrinsic motivation, such as getting rewards for getting your steps in. But there's very little focus on how to increase the intrinsic motivation, which is the motivation that comes from inside. We know through social contagion theory that behaviors can spread. So people who, a common example is smoking tends to kind of catch on in groups of people. And so behavior change can also spread, but we are not really harnessing the power of social contagion. We have built our own behavior change model that focuses on the dyad between a person who's receiving or 2 people who may be receiving and giving care. And there are frameworks around caregiving at home specifically. There's one called Technology-Enabled Caregiving at Home, that talks about how we can really build theory-based tools. And with that, I'm going to hand it back to Sonu to bring us home.
Okay, thank you, Ranak. I will share the slides and take us through you've heard us talk about the hype. Now we're going to talk about what does it take to actually deliver on the hope and the promise. Whoops, I do not want to share my slides with you. I want to do a slideshow. So this slide over here actually shows you the cover of a book called Artificial Unintelligence: How Computers Misunderstand the World. And the biggest takeaway from Meredith Broussard's work for me in this book was this idea of techno-chauvinism. Just because technology can do something for us doesn't mean we should. I am the proud owner of a car, an electric car, Tesla, that is capable of driving itself. I never have activated the self-driving software, and I never will. Just because I can does not mean I should. My colleagues at the National Academy of Medicine, another group where I'm part of a group that looks at using technology and innovation, including AI and others, for advancing care in an equity-based paradigm, published something a few years ago. And in that paper, we had a call for action for many groups, and I'm going to extract from that. This slide extracts what we showed the opportunities to lead for anybody who does this work. And we said that they need to integrate the responsibility for achieving equity, and that to listen and amplify underrepresented and individual and community voices as we put equity as a central goal, because without it, progress indices are not meaningful. Yuval Noah Harari, in his book 21 Lessons for the 21st Century, argued humans were always far better at inventing tools than using them wisely. What is wisely? I'm going to offer you a couple frameworks for wisely in this space of AI, because it's a black box, but also for any form of innovation. One is the quintuple aim that you heard me mention earlier. We know that which is measured improves. So we need to measure what I used to call equity and inclusion and now call justice, equity, diversity, inclusion, or JEDI. Another framework for wisely also comes from that same publication in 2019. And this screen shows a series of questions and things to think through about implementing AI through a lens of a human rights value, which will require friction. It's not going to be taking a hot knife through butter. We have to ask ourselves what we value. As you heard earlier, I spent 25 years in tech before coming to Stanford, and I continue to have a number of friends who continue to be leaders in tech. And they often argue that I'm asking them to put a pause on progress. And I said, how do we define progress? How do we define quality of life and well-being? And finally, who knows, who decides, and who decides, which is all about who has the power and what are they prioritizing. There is this concept of Ubuntu that comes, and this quote is from Archbishop Desmond Tutu. And I argue in order to deliver JEDI, we need Ubuntu. And he says, one of the sayings in our country is Ubuntu. Our country for him is South Africa. The essence of being human. Ubuntu speaks particularly about the fact that you cannot exist as a human being in isolation. It speaks about our interconnectedness. We think of ourselves far too frequently as just individuals, separated from one another, whereas you are connected, and what you do affects the whole world. When you do well, it spreads out. It is for the whole of humanity. This is the framework that's used in restorative justice models, similar to what one sees in truth and reconciliation commissions, where we first start asking about what harms are we already creating in our systems or have created in the past? What are the needs of the people that we are prioritizing and need to prioritize? And thus, what are our obligations? And I argue that lacking our own guardrails, we have already ended up in a world of guards and gates. History teaches us the next step is revolutions. I'm going to end with a quote from a JAMA paper my colleague and friend Abraham Verghese and I wrote back in January of 2019. We titled it Humanizing Artificial Intelligence. We said humans in need want the best of what science and medicine have to offer, particularly in the set of serious and chronic illnesses. Patients in need want their physicians to be human beings who care, communicate clearly, and are compassionate and express empathy. As Peabody famously observed long ago, one of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. Bettering the ability of physicians to truly care for and express caring is the challenge for colleagues in computer science and medical informatics. Systems that augment the diagnostic and scientific task of treating disease are exciting and wonderful, but is it possible to invent and discover applications that can enhance the human abilities in clinicians to better engage in caring for the patient. Thank you very much. I'm going to stop sharing my screen and turn it over to Jennifer.
Thank you so very much, Ranak and Sonu. This was amazing.